Hello and welcome. This presentation, Newborn G6PD Deficiency Screening, Why It Is Necessary and When It Must Be Performed, is sponsored by the G6PD Deficiency Foundation. Our mission is to raise awareness and increase education about G6PD, and most importantly, to mandate the screening of G6PD in newborns. It is this mission that has birthed the Brody-James Bill. We'd like to introduce you to the namesakes of this bill. First, meet Brody. Brody was born in 2013. He was discharged from the hospital 3 days after his birth. He had not been tested for G6PD deficiency prior to his discharge. Within days of being at home, he became jaundiced. When his parents took him to see the pediatrician, they were told not to worry, that jaundice was expected because he was 2 weeks early. 7 days after his birth, during a morning visit with his pediatrician, Brody appeared yellow, listless, was producing dark urine, and he was not eating. He was sent to the hospital for a bilirubin count. When he was finally admitted, his condition had progressed from hyperbilirubinemia to kernicterus, or brain damage. 14 days after his birth, he was diagnosed with G6PD deficiency. Brody's parents had never heard of G6PD deficiency, nor had they been educated on the signs of serious jaundice. And because of Brody's outward appearance, his pediatrician had not considered G6PD deficiency as a potential diagnosis. Brody is now struggling every day with cerebral palsy that would have been avoided if he had been screened for G6PD deficiency prior to his discharge. This handsome dude is my son James, who was born in 2000. 3 days after his birth, his bilirubin was elevated. The doctors told us that they would watch this closely and that phototherapy would be used. James was slightly jaundiced when he was discharged 6 days after his birth. His doctors indicated that this was normal. He was not tested for G6PD prior to his discharge. 11 days after his birth, we took him in to see his pediatrician. We told them that James had had difficulty feeding, he was producing orange urine, and he generally lacked energy. The pediatrician noted that he was still jaundiced and instructed me to supplement breastfeeding with formula. 13 days after his birth, James was readmitted to the hospital. His condition had progressed from hyperbilirubinemia to kernicterus, or brain damage. 2 weeks after that readmission, James was diagnosed with G6PD deficiency. Because of G6PD deficiency, James became a nonverbal, non-ambulatory, G-tube fed, and hearing impaired child. James passed away at 20 years of age due to complications from cerebral palsy, a condition that was developed from the kernicterus that was caused from the undiagnosed G6PD deficiency as a newborn. Specifically, he was unable to roll over when he fell forward, and that inability to roll over was directly linked to his kernicterus. As a result, when he fell, he suffocated and died. By now, you're probably wondering what G6PD deficiency is. G6PD deficiency is a common genetic enzyme disorder linked to the X chromosome. G6PD is an enzyme critical to the health of red blood cells. When G6PD deficiency is passed to a child, his or her production or activity of G6PD is impaired. Reduced amounts of G6PD make the red blood cells break down, or causing hemolysis due to oxidative stress. Hemolysis leads to a myriad of health conditions, including kernicterus. Many people do not know that they are G6PD deficient. When a newborn is experiencing symptoms of hemolysis as a result of being exposed to oxidative stress, they can experience a wide range of symptoms. Some of the symptoms that you see are ones you've heard before in both James and Brody's stories. And while this list is very extensive, it is by no means exhaustive. It is also important to note that a newborn can experience any one of these symptoms or any combination of these symptoms while experiencing hemolysis. G6PD deficiency is one of the most common hereditary enzyme deficiencies in the world. Approximately 5% of the world's population is G6PD deficient. That's 400 million individuals. In the United States, there is higher incidence of G6PD deficiency in individuals who are of African American descent, Mediterranean ancestry, East Asian, and Hispanic descent. James, for example, was both Native American and African American, whereas Brody is of Mediterranean descent. Screening newborns of G6PD deficiency requires quantitative testing instead of qualitative testing. Qualitative testing is the commonly known dried blood spot test that is prevalent in New York. This kind of testing, however, is problematic when screening for G6PD deficiency. One reason this is true is because the results are not received until 5 days after the testing is completed. In other words, those test results are not available prior to the newborn's discharge. In addition, it only tells you if a person is 30% deficient or less. In other words, if you are 31% or more deficient, you will not be detected in the qualitative testing. Quantitative testing, by contrast, can be performed on-site or with a point-of-care device. They come back immediately. The results are provided prior to discharge from the hospital, and it will reveal any and all patients and how deficient they actually are. Why must all newborns be tested for G6PD prior to their discharge? First and foremost, for the welfare of that infant. If a newborn is G6PD deficient, they are much more vulnerable to the damaging effects of hyperbilirubinemia. And this hyperbilirubinemia can lead to severe brain damage known as kernicterus, or a more subtle form known as bind. Kernicterus can develop within the first few days after birth, generally after being discharged from the hospital. And studies have shown that the underlying root cause of kernicterus is the inability to identify an at-risk infant and manage hyperbilirubinemia. In addition, a newborn that is experiencing a hemolytic event is going to experience a false negative of a G6PD deficiency reading if tested during that event. So it is critical that newborns be tested prior to discharge and prior to experiencing those events. You should also know that testing for G6PD deficiency in newborns is routinely performed in countries where prevalence is greatest. The U.S. military tests all armed services individuals for this condition to prevent use of contraindicated therapies, such as drugs for malaria. Certain COVID-19 therapies are also contraindicated for G6PD deficient patients. Annually, it is estimated that the cost of treating one newborn with kernicterus fiscally exceeds the cost of screening all newborns for G6PD. In the United States, when looking at the cost-benefit analysis of screening G6PD in newborns prior to discharge, we only have ratios based on mortality and morbidity of kernicterus. Therefore, our figures are conservative. And as you can see by the table before you, even if the cost of screening per child is $20, the net benefit is positive. It is also important to note that we do know that 30% of newborn readmission for severe jaundice is caused by G6PD deficiency. The UK has done much more extensive data collection that gives us a much clearer picture of the cost-benefit analysis of screening newborns for G6PD. As you can see by this table, at the same cost point of $20, the benefit is exponentially higher than our conservative numbers in the previous table. Given everything that you've heard, why wouldn't you support the Brody-James bill? This bill will mandate quantitative newborn G6PD deficiency testing prior to discharge, and the results are massive. Having these test results prior to discharge will guide all medicinal and therapeutic treatments for that infant. Identification of this deficiency at birth protects that infant from life-threatening conditions and life-threatening treatments. In other words, healthy babies will remain healthy. Clinicians will have the opportunity to educate parents on jaundice and oxidative triggers, which will further protect that infant in the future. This will prevent the development of kernicterus. And as our cost-benefit analysis revealed, the cost of screening every newborn for G6PD deficiency is far less than the cost of treating one newborn of a lifetime of medical costs. New York State is in urgent need to implement the point-of-care biological testing for G6PD due to its diverse, multiracial, and ethnic population. And most excitingly, not only will New York State residents benefit from this testing, creation of this policy will most certainly reverberate nationally. So New York has the opportunity to be the trendsetter of actually impacting children not only within their own state, but nationwide. Thank you so much for your time today. If you have any questions, please contact the G6PD Deficiency Foundation. And thank you from Brody's and James's families for your time and attention and support.